Sound check, sound check. All right, folks, it's Professor Gulliford here, longtime member of the faculty. And what I'm doing is preparing for you a TMC review sheet to help you prepare for your exam. I've been working with, actually hundreds of IU students and graduates as they get ready for their TMC exams. And I get a lot of questions. I get questions about terminology. I get questions about how to modify therapy. I get questions about hemodynamics. I get lots of questions. And what I thought I would do is prepare a review sheet and just answer a lot of those in a way that might help everyone. So let me do this. I'm going to do a share screen, share computer sound, optimize for video, and we'll share the screen now. And then I'll put up this review sheet, which has been growing for several months now as we do reviews with students. And you should see now a review sheet for the TMC exam for 2017. I'd like to start with some terminology. I've gotten lots of questions about methemoglobinemia. Methemoglobinemia, and this is the condition that causes your blood to turn chocolate brown. I've only seen this in clinic a couple times, but it's usually due to a poisoning situation. Nitrite toxicity is famous for doing this. Once in a while we confuse sodium nitrite with some other chemical. It gets in the food supply, and it's a very, very bad situation. So you do hemoximetry to see how much of that methemoglobin is present, how much of other types of hemoglobin are present. Chocolate brown blood, methemoglobinemia, and that would be nitrite toxicity. There are some other things that cause it, but that's probably the most common type. Hemoximetry is the same thing as co-oximetry. At the hospital, at least at my hospitals, we say co-oximetry. However, hemoximetry is the same thing, and that's likely what you're going to see on your test. So hemoximetry is used to measure carboxyhemoglobin and other types of hemoglobin, like methemoglobin. The crucial test in carbon monoxide poisoning is hemoximetry. Crucial test. Empyema. I've had several students who confused this with emphysema, and let me tell you, if you make that confusion, you can't get the exam question right, whatever it's about, okay? Empyema is pus that builds up in the pleural space. I think the reason that students may not have heard this term very often is we don't see much empyema anymore. That's because we treat pneumonia much better than we used to, and pneumonia generally does not spread to the pleural space to create an empyema. Risk factors for empyema: pneumonia, tuberculosis, chest surgery, lung abscess, trauma. You're going to hear decreased breath sounds. You would have a dull percussion note. It doesn't mention that here, but a dull percussion note. And you would hear a friction rub because the pleura are separated by this infected material. So treatment is chest tube. Get a chest tube in about the 5th intercostal space, probably, and then let gravity help with the drainage of the empyema. All right. Here's a term that I did not know myself until a student asked about it last week. It's phosphatidylglycerol. Phosphatidylglycerol, PG for short, is obtained by amniocentesis, and when it's there in the amniotic fluid, it indicates the baby's lungs are mature. It's not a particular level of it. It doesn't have to be a certain number of milligrams or whatever. It is simply the presence of phosphatidylglycerol, PG, means the baby's lungs are mature. Thorpe tube. Every day in clinic, you work with a oxygen flow meter that plugs into the wall. It's got the little ball that floats, all right? You may not have heard it called a Thorpe tube, but you definitely need to know that it's a Thorpe tube so that you can answer a question about it if you get one. By the way, I don't have any idea what questions you will get on your test. Every test is different, but we've heard many, many times students asking, what's a Thorpe tube? So certainly you're going to need to know. A Thorpe tube is a standard flow meter. A Borden gauge is the regulator that you have used for a long time on oxygen tanks, for example, for transport, okay? Wouldn't want to transport with a Thorpe tube. The little ball would just roll to the top, it won't work. Borden gauge is for transport. Eupnea simply means normal breathing. Any medical term with EU in front of it just means good. So this is good breathing, no distress. And you won't see BiPAP on your test, although we use that every day. What you'll see instead is NPPV. That is non-invasive positive pressure ventilation. NPPV, non-invasive positive pressure ventilation. BiPAP is actually a trademark term registered to a particular company called Respironics Company. Okay, you need to know about cardiac output and cardiac index. Let me scoot those up so they'll be easy to see. Cardiac output, normal range is 4 to 8 liters per minute. That's how much blood your heart pumps every minute. And the Fick equation is the equation that is used to calculate cardiac output. Cardiac output, Fick equation. Cardiac index, however, is cardiac output divided by body surface area. So it is indexed to the body surface area. And since body surface area is about 2 for most patients, the normal range for cardiac index is about 2 to 4 liters per minute per square meter. And it is liters per minute per square meter would be the units for the cardiac index. Cardiac output, 4 to 8, cardiac index, 2 to 4, and Fick equation for cardiac output. Let's move ahead. Number 3, ventilator waveforms. Several students have asked about the beak for overdistension, and that's at the top right there on this little graphic. The beak is overdistension. That's where you would need to reduce tidal volume, reduce peak pressure, do something to bring down the overdistension which is taking place. Also be sure to check for air leak, reduced compliance, increased resistance, inadequate flow. They're all shown right here on this graphic. And you could have any of those, and you may have several of them on your test. We don't know, what your exact test is going to be. But I would review all of these. The beak, probably just because it's kind of unique, is one that several students have asked about. Assisting doctors with procedures. 2 key things to know. If your patient is bleeding during bronchoscopy, like maybe we took a biopsy and caused them to bleed, then you would administer epinephrine down the scope. If they're coughing during bronchoscopy, then administer lidocaine down the scope. With the pulmonary function testing, you definitely need to know the spirogram or the boxes, and I'm going to share that a little later and go over it in detail. But for example, the FRC, which is a very important measurement, is ERV plus RV. That's the expiratory reserve volume plus a residual volume equals the FRC, the functional residual capacity. And there's a great mnemonic device for this. I'll share it later. PFTs. Which volumes and capacities are increased or decreased in various obstructions or restrictions? This is a key concept for you to understand. TLC and vital capacity decreased in restriction. That means less than 80% of predicted. That's the definition of restriction. FEV1 to FVC ratio is decreased in obstruction. It's less than 70%. That's the definition of obstruction. So you must know that. We're going to share a little more detail later, but that's a key concept that you must have. TLC and vital capacity decreased in restriction, less than 80% predicted. FEV1 to FVC ratio decreased in obstruction, less than 70%. What does PEEP really do? You ever thought about why PEEP actually works? Well, what it does is it decreases the AA gradient, the big A minus the little a, O2. And it does that by increasing the FRC that we were just talking about. As the FRC increases, there's more surface area exposed for oxygen to diffuse and more time during the respiratory cycle for oxygen to diffuse. So that's what PEEP really does. We've had quite a few questions about PEEP. Asthma in the emergency room, albuterol and prednisone. What you want to do is distinguish the short-acting agents, things that will help relatively quickly, versus long-acting agents. Brovana, poor choice in the ER. Symbicort, poor choice in the ER. But albuterol and prednisone, good choices. Stridor in the ER always should get racemic epinephrine. And later on, we're going to talk about croup versus epiglottitis so that you can help to distinguish those two. But for this point, just infant with stridor in the ER, racemic epinephrine. Transcutaneous oxygen, the TCO2, this surprises people. The temperature of the sensor should be 44 degrees centigrade. which is well above body temperature, 37 degrees centigrade. So that raises the question, won't that burn the infant? Well, it could. So we have to move the sensor often to make sure that doesn't happen. As often as every 2 hours can be done. Every 2 or 3 hours could be the answer to that. PEEP and its effects on blood pressure. This is a key concept and way too much to cover in a lecture of this nature that I'm doing right now. But there's a video that's awesome. So when you get this review sheet in the email, then you will go to this YouTube video, and it does a great job of explaining to you the effects of PEEP. 10 minutes, I think, is all it takes. Heliox, we've had several students asking us about Heliox, and I think the reason is we don't do Heliox very often, and consequently, we're not sharp on Heliox, but you need to know it for the test. For 80-20 mixture of Heliox, the ratio is 1.8, so you would simply multiply the oxygen flow meter reading times 1.8. If the oxygen flow meter says 10, then it's actually 18 liters of Heliox coming through. If the mixture is 70-30, the ratio is 1.6. So, and I provided an example here, if the patient's on 80-20, flow meter at 10, then the actual flow is 18. You might be asked to calculate this. I don't know what question you might get. You might be asked to calculate it, or maybe just to state what the ratio is, something like it. For pediatrics, how do you prepare for pediatrics on the TMC? You're going to have some questions, but not a huge number of questions. I recommend this little video that really shows you how the oscillator works. It's a great video, and it's actually done by an RT student as a course project that she was doing, but she does a super job of explaining this. So check this out when you get this review sheet by email. Maybe you've already got this review sheet by email. Capnography waveforms and what they mean. A classic example, everybody likes the shark fin because, it's kind of a cute shape, I guess, or whatever. But the shark fin on a capnography waveform means bronchospasm. Could be asthma, could be COPD. So what would you do for shark fin? You'd give them a bronchodilator. Hypoventilation is also on here, those big, wide waveforms. Hyperventilation, the fast waveforms. You could have any of these on your test, so just be sure to review all of them here. Okay, calibrating nitric oxide and capnography. What I decided to do there was give you 2 excellent videos. The first one's on nitric, the second one's on capnography. If you watch these little videos, they're not very long, they will tell you everything you need to know about that. Capillary blood gases. We do a lot of capillary blood gases in babies, of course. Can we trust them? Well, the answer is we can trust part of them. We can trust the pH and trust the PCO2, which are very similar to arterial. But the O2 will be lower, significantly lower. So it's important to understand that. You can trust the pH and PCO2. They're similar to ABGs, but the O2 is going to be considerably lower. Modifying therapy based on blood gases. I have a whole handout for you on this, which comes up later in this little presentation. But a key concept is raise the FiO2 to 60%. And if you still don't have adequate oxygenation, then you start adding PEEP instead of going up to 70%. Hemoximetry. All right, we talked a little about this earlier, but make sure you know hemoximetry is the same thing as co-oximetry, and it's used to detect carboxyhemoglobin, methemoglobin. If the pulse oximeter reads different from the true oxygen saturation coming from the hemoximeter, then carboxyhemoglobin is a very likely cause. Review the physical exam, the meaning of percussion notes, expansion, fremitus, crepitus. For example, dull percussion might be pneumonia, might be pleural effusion. Hyperresonant percussion might be pneumothorax, might be emphysema. Expansion, a decreased expansion of part of the chest, might be a large pneumonia or a large atelectasis. Fremitus is increased in pneumonia and other consolidation type conditions. And crepitus is the air in the soft tissues around the thorax, which could mean there's an underlying pneumothorax. Just a few examples. Emphysema. Let's use emphysema as an example of the physical assessment. Barrel chest, which is an increased AP diameter of the chest. That's a different way to say it, but that may be what you see. Increased AP diameter, hyperresonant percussion note, diminished breath sounds. That is classic emphysema. Pneumomediastinum, you'll see air in the center of the chest around the bronchi. This is item 22, pneumomediastinum, air in the center of the chest around the bronchi, around the heart. And let's talk about chest x-rays. I've got a very good handout for you on chest x-rays, but here at chest x-ray, if the film is rotated, then the heads of the clavicles are not an equal distance from the midline. If the clavicle heads appear to be not the same distance from midline, that is a rotated film. We often see that on a portable chest x-ray, for example. And if the chest x-ray is overexposed, meaning very black, or underexposed, which is very white, that is overexposed, very black, underexposed, very white, that also needs to be recognized. Make sure your patient gets enough flow rate. As I've been doing practice exams, I'm doing the Kettering practice exams, lots of them with students. And as we do those, we keep running into situations where we need to increase the flow rate to make sure the patient has enough time to exhale. Key concept, the patient must have enough flow rate, which means a short enough inspiratory time, so they will have enough expiratory time to exhale. Changing alarm settings, just in general, the principle is this: don't change the alarm setting, fix the problem which is causing the alarm. That's a key concept for you. Yeah. In fact, the item just above that was a classic example. Let's say the patient doesn't have enough time to exhale, so we're getting alarms because of that. Then we need to increase flow rate to fix that problem. Now, the only time you might change an alarm setting is if the patient has actually improved. Like, let's say their lung compliance has gotten much better, then you may need to actually adjust alarms in that case. Normal airway resistance, I'm on number 27, is 0.5 to 3 centimeters of water per liter per second. This is also sometimes called RAW, capital R-A-W, airway resistance. The normal range, 0.5 to 3. So let's say you had a patient on your test with an airway resistance of 5. Well, that is high airway resistance, as you might see in bronchospasm. Okay. When to recommend bronchoscopy? An example might be a patient who is losing weight. They have protein in their pleural effusion. Maybe they've got cancer. That would be a good time to recommend bronchoscopy. Bronchoscopy for bronchial lavage to get a culture would be another good example. So you need to know why it is we do bronchoscopy. Mixed venous blood. We've had several students inquire about mixed venous blood. What is that? Well, it comes from the pulmonary artery, and you get it through the Swan-Ganz catheter, which on your test will be called a balloon tip flow-directed catheter. Balloon tip flow-directed catheter. The pulmonary artery is where mixed venous blood comes from. For cardioversion versus defibrillation, you might have something like this on your test. Cardioversion must be synced on the R wave in order to be effective. So cardioversion is synchronized on the R wave. Defibrillation is not. That could be something you see in your test. This is a duplicate because the professor, frankly, is getting a little older and forgot. I already covered this, but it won't hurt you to hear it again. Nitrites. Nitrites cause methemoglobin to appear in the hem oximetry. And by the way, chocolate-covered colored blood. Change the IE ratio with inspiratory time, flow rate, expiratory time. The inspiratory time needs to be short enough to give the patient time to exhale. That is a key concept. You might do that by decreasing inspiratory time. You might do it by increasing flow rate. You might do it by increasing expiratory time. Chest x-rays, we're going to give you a whole handout on chest x-rays, but one you definitely need to know is vascular engorgement and the butterfly pattern. Butterfly pattern, that's pulmonary edema. Various trach tubes could show up on your test. We've had several questions from students about fenestrated trachs. To ventilate that fenestrated trach patient, you must put the inner cannula in place and inflate the cuff. That's because the fenestrated trach is a talk trach, which is designed to let air go through the patient's vocal cords. That's great, but if we need to ventilate that patient, we need to create a seal by putting the inner cannula and inflating the cuff. All right, we're on number 36. If a trach patient is not ventilating and you cannot pass a suction catheter, don't mess around. Just change the trach tube. You may have a mucus plug that's completely blocking the tube. We don't know exactly what's wrong, but if the patient can't ventilate, you've just got to change the trach tube. Okay, confirming tube placement. We want the tip of that ET tube to be about 3 to 5 centimeters above the carina. For adults, we can also look at the lips. Should be about the 23 centimeter mark at the lips. Those are good ways to confirm tube placement. Also, lung sounds, of course. Should hear good lung sounds on both sides. Endobronchial intubation is what we're trying to avoid. That's tube down the right main stem. And that would be detected by decreased expansion on the left, decreased or absent breath sounds on the left. Endobronchial intubation needs to be quickly identified and fixed. If your patient has too small of an ET tube, you will not be able to wean them. Imagine trying to breathe through a very small ET tube while you're trying to come off the ventilator. It's not going to work. So you must change the tube. You must get to a tube size which will actually work for the patient to be weaned. Obstructive versus central sleep apnea, very important to understand the difference. In obstructive sleep apnea, you will see respiratory efforts. The patient's trying to breathe, but they're not able to move air because they're obstructed. CPAP is the treatment that works for millions of Americans with that problem. Central sleep apnea, no respiratory efforts are seen. That's because it's a problem from the central nervous system. We don't see signals coming down to make the diaphragm move, so no respiratory efforts and no air movement. You must do bilevel ventilation. Here, CPAP is not sufficient. Nasopharyngeal airway, if anytime you have a problem with a nasopharyngeal airway, just change it. There's no difficulty in changing a nasopharyngeal airway. So just swap it out. Here's that terminology from the very start of this presentation, Thorpe tube versus Borden gauge. For transport, you cannot use a Thorpe tube. The little ball would simply roll to the top of the flow meter and you don't know what you've got. So use a Borden gauge, which is a regulator. Thorpe tube is just a normal flow meter. We hardly ever call it a Thorpe tube at the hospital, but that's its actual name. So when the student asked me that, I actually had to think myself, which one is the Thorpe tube? Thorpe tube, flow meter, Borden gauge, regulator. Auto PEEP is a big issue for the NBRC, and it ought to be because it's a huge problem for our patients. To get rid of it, we give the patient more time to exhale by increasing flow rate, decreasing inspiratory time, increasing expiratory time, thereby improving the IE ratio. Heliox, many students have asked about Heliox, and that's because you don't do it very often. You must use a non-rebreather mask for Heliox. We went over the ratios a little while ago, but for Heliox, be sure to use a non-rebreather mask. Okay, in addition to PaO2, what tests should you do to determine oxygen delivery? Well, you've got to get the hemoglobin level, right? You need to know how much hemoglobin they've got. And the way you do that is a CBC, a complete blood count, which includes red cells, white cells, the differential, and the hemoglobin and hematocrit. So definitely get a CBC so you know the hemoglobin level. Very important for every patient. I can't think of a single patient that you wouldn't get a CBC for. PIP and plateau, this is a challenging thing for students. If the plateau stays the same, but the PIP goes up, that's an airway resistance problem. Let me say it again. If the plateau pressure stays the same, but the PIP goes up, peak inspiratory pressure goes up, that's an airway resistance problem. If the plateau and the PIP go up the same amount, that's a lung compliance problem. Let me say that again. If the plateau and the PIP both go up the same amount, that is a compliance problem. All right. Nasal cannula flow rates. This one is simple, but just want to make sure that you understand it. It's 4% per liter of cannula flow plus room air. 4% per liter plus room air. Room air's 20%. We're going to go with 20 to keep it simple, all right? So a cannula at 3 liters, you simply go 3 times 4 is 12. 12 plus 20 is 32. That is 32% oxygen, 32% FiO2, assuming the patient has a normal ventilatory pattern. Now, if they have a rapid or irregular ventilatory pattern, then you would move to an air entrainment mask, and that's terminology, okay? Air entrainment mask. At the hospital, you might call it a Venturi mask, but it's an air entrainment mask for the test. Then you would move them to that same FiO2 on the air entrainment mask. 4% per liter. EKGs, just know what PDCs look like. Remember to pre-oxygenate before suctioning to avoid them. Also, limit the amount of time you suction. Suction should be done for less than 15 seconds. Do you remember that? Suctioning should only be done for 15 seconds. Cystic fibrosis, we've had some questions about that. Remember to add DNase, known as pulmazine or Dornase alpha, for these patients with cystic fibrosis. Calculating alveolar ventilation. It's not a tough calculation, but you need to know how to do it. You take tidal volume minus dead space and then multiply by the respiratory rate. And remember that patients have 1 milliliter of dead space per pound of ideal body weight. So for a 150-pound patient, you got 500 minus 150. That's 300. The professor made a mistake on this one, folks. Let's take 450 minus 150 times 12. That's 300 times 12. And that's 3,600 milliliters or 3.6 liters. I made a mistake there, folks. But you just take the tidal volume minus the dead space times the respiratory rate. Just prove that I'm not perfect either. Minute ventilation is easy, just tidal volume times respiratory rate. All right, calculating tank flow duration. You very likely will have one of these on your test. The H tank factor is 3. The E tank factor is 0.3. So if you just take that tank pressure, and a full tank is 2,200 PSI, and then multiply that by the factor and divide by the flow rate, that gives you the duration of flow in minutes. Then you must remember to divide the minutes by 60 to get hours. So tank pressure times the factor, which is 3 for H tanks and 0.3 for E tanks, then divide by the flow rate. That gives you the duration of flow in minutes, and then you divide by 60 to get hours. Rapid shallow breathing index, you very well may have something about this. That's kind of a new and important way of looking at weaning readiness. Take the frequency, that's the respiratory rate, divided by the tidal volume in liters. We want it to be less than 105 in order to effectively wean the patient. We want this to be less than 105. So the frequency divided by the tidal volume gives you the RSBI. I did an example here for you, which is 25 divided by 0.35 liters, 350 milliliters is 0.71. That's 71, which is well less than the 105, ready to wean. Higher than 105, they are not ready to wean. What's the best index of oxygen transport to the tissues? Well, it's the CaO2. And I don't believe that you're going to see a lot of calculations. I wouldn't think that they would ask you to calculate the CaO2 on your test, but you do need to know that CaO2 is the best index of oxygen transport. APGAR, scores of 7, I say lucky 7, like Las Vegas, like 3 7s on the slot machine. APGAR, score of 7 or above is good, and APGAR is performed at 1 minute and 5 minutes after birth. Less than 7 means you need to do something, and we're going to go into that in considerable detail here a little later in the presentation. Review all the lung sounds and what they mean. I provided the actual American Thoracic Society classification here. Crackles, wheezes, rhonchi, stridor. It's all right here for you to review. Crackles, coarse crackles, probably pneumonia. Moist crepitant, fine crackles, CHF or pulmonary edema. Wheezing, asthma, foreign body, tumor. Rhonchi, secretions that may clear with coughing. Rubs, pleurisy would be a classic example. And stridor, croup, or post-extubation. Moving ahead. Oh, here is just more detail on the various airway sounds. The crackles, which can be called rowels. The rhonchi, the wheezes, the stridor. Just review that whole section right there. Congestive heart failure. This results in edema And Lasix, which on your test will probably be furosemide, is used to treat that. Ventilator loops, review all of them. Make sure you understand that beak, meaning overdistension. Many students have commented on that one. PFT, which lung volume cannot be measured by spirometry? It's the residual volume. You have to have a body box or helium dilution or nitrogen washout for that. Review the proper way to teach your patient how to use an MDI. And I think I've got a video for you on this. No, I've actually just got a handout for you. How to use a meter dose inhaler. This is a great way to describe it. If you will just review this, this is how you teach the patient to use an MDI. All right, we're making progress here. Oxygen humidifier, if it's whistling, that is an alarm. It's actually a 2 psi pop-off. And what that means is that the tube is obstructed or kinked. Let's say you've got the suction set correctly, but there's no suction coming through, then you've probably got a leak. Check the connections, check for a leak. Maybe the tube is not connected tightly to the reservoir. That would be a good example of how that can happen. And then here come your chest x-ray descriptions and treatments. I decided to just include all of them here for you. Pulmonary edema, the butterfly or bat wing, atelectasis, patchy or plate-like, ARDS, honeycomb or ground glass, pleural effusion, blunting, pneumonia has air bronchograms, pulmonary embolus, wedge-shaped, tuberculosis, cavity, and then the various kinds of treatments that might be applied. That's a great little handout right there. I would really spend some time with that. And then also the chest x-ray terms like radiolucent, dark, radiodense or opacity, that's white, infiltrates, consolidation, hyperlucency is extra air or extra blackness, vascular markings, diffuse, opaque, and then this could show up on your test because it's classic respiratory therapy. Croup is the steeple sign, also known as a pencil point sign, and epiglottitis is the thumb sign. I think that'll be a very helpful little handout for you. We're getting close to halfway done, folks, so hang in there. Tracheal deviation. Lots of things push the trachea, lots of things pull the trachea. So take a close look at this. Tracheal deviation, atelectasis pulls, pulmonary fibrosis pulls the trachea. Pneumonectomy, diaphragmatic paralysis, all those things pull it toward the pathology. Things that push it away, pleural effusion, pneumothorax, tumors, mediastinal masses. The first two would be the most common, pleural effusion and pneumothorax. And here's a little summary of PFTs, which I think I already actually mentioned, but this also includes the severity indicators, normal, mild, moderate, and severe, based upon percentage of predicted. The shortcut for ideal body weight, you have to know this, folks. 50 kilograms plus 2 times the inches above 5 feet in height. That gives you the ideal body weight. If it's a male, add 2 more kilograms. And then I give you an example here of how you would actually use that to determine ideal body weight. Then you can use that to set tidal volume. If you use this and just put a 0 after it, then you will have the upper limit of tidal volume, which would be 10 milliliters per kilogram. Typically today we're using closer to 8 milliliters per kilogram. Tips to picking the right ventilator settings. Do not rule out an option because of mode alone. Don't choose on the basis of mode. Do not exceed a PIP of 35 in pressure control. Do not exceed a PEEP of 8 for infants. Put the patient on the same FiO2 on the ventilator that they were receiving before ventilation, and never add mechanical dead space in SIMV. Those are some very useful tips. Those came from a professor colleague of mine, Mr. Jim Greens. Exhaled nitric oxide testing for asthma. We measure nitric oxide in the patient's exhaled breath to monitor the corticosteroid use. The nitric oxide level comes down as the steroids are working and producing their anti-inflammatory effect. Now, you could have a question on your test about carboxyhemoglobin. Very likely, because it's so important, so crucial in the ER. And if you do, you need to know these normal levels. Normal is 0 to 1% carboxyhemoglobin. Smokers, 2 to 12. And carbon monoxide poisoning is defined as greater than 20. Right? For myasthenia gravis and Guillain-Barré, I would guess that you're going to have some neuromuscular problem on your test. We need to very carefully monitor the tidal volume, vital capacity, and MIP on these patients. Oops, I think I already shared this with you. Okay, folks, here's a duplicate. This is the capnography waveforms. Again, that's how important they are. It won't hurt you to review them twice. Okay. Let's move on down here to wheezing, unilateral wheezes. This could be a foreign body, especially in kids. Could be tumor in adult patients. You would certainly recommend a bronchoscopy if you had a unilateral wheeze in a patient. The ARDS chest x-ray, diffuse, radiopaque. Here's a term that we hardly ever hear at the hospital, but could show up on your test. Reticulogranular. Reticulogranular. Airway resistance and lung compliance. Pretty sure we've already covered that. Here's something that you really need to review. Lung volumes and capacities. Wow. You're going to have some of this on your test. We've got the tidal volume, which is normal breathing. Above that, the inspiratory reserve volume. Those two together make up inspiratory capacity. Then we've got expiratory reserve volume and residual volume. The two of those together make functional residual capacity. And everything from the top down to the residual volume is vital capacity. The whole thing, total lung capacity. And there is a great little mnemonic device which is used to help you remember this. I love this thing. I wish I knew who created this. The loving couple went on vacation in their RV. They took along fried chicken and ice cream. Their kids, Irv and Irv, watched TV in the RV while they traveled. I think that is absolutely priceless, and it will help you to remember how to handle these various volumes and capacities. Unilateral lung disease, good lung down. If the patient has a bad lung and a good lung, we go good lung down to improve their VQ matching. Bronchiectasis, Pseudomonas is the common infection with a foul odor and green sputum. Just need to know that. Eupnea, we covered that at the top of this presentation. Lateral Fowler's, that's a position in which we have the patient in Fowler's position but turned to their side. This may be helpful for seriously obese patients to help them breathe. And I just want to make sure you know the word adventitious. We don't say that at the hospital very often, but adventitious is any abnormal breath sounds like crackles, wheezes, and rubs. Meanwhile, vesicular just means normal lung sounds. Vesicular, normal lung sounds. High-frequency oscillator ventilation, we should see chest wiggle. If it is set correctly, you should see chest wiggle. Thoracentesis, transiudate versus exudate. This very well could show up on your test. The transiudate is clear. CHF is a common example. It's called serous fluid. Meanwhile, the exudate is cloudy or opaque, more like pneumonia or cancer. pH less than 7.3 means exudate. High troponin level, that's your indicator of a heart attack. So we go with, oh man, you've probably heard this mnemonic. If you haven't, then here you go. But high troponin level means heart attack. We go with oxygen, morphine, aspirin, nitroglycerin. Okay, here is sleep apnea, obstructive, and central. We've covered that. What if the patient has significant weight loss and dry cough? Recommend bronchoscopy. To clean and disinfect the bronchoscope, glutaraldehyde. You know, we don't do a lot of disinfection in the RT department anymore, but you need to know that we disinfect with glutaraldehyde, 2%. Brand name is Cydex, but it'll be called glutaraldehyde, I'm sure. Lateral decubitus chest x-ray. This is where we lay the patient on their side and we watch the fluid run up the side of the chest. That indicates it is an effusion versus an infiltrate. Lateral decubitus film done to detect and measure pleural effusion. Let's say you have a patient with an unstable respiratory pattern. That's when you should use a Venturi mask, which is also known as an air entrainment mask. Heliox therapy, non-rebreather mask. I think I mentioned that before. Sinus bradycardia, treat that with atropine and oxygen. Atropine is the classic medication to treat sinus bradycardia. That would be a heart rate less than 60. Okay. Here is a great handout on correcting ABGs. A good portion of your test, folks, is going to be how do you fix ABGs with ventilator settings. And it's all summarized right here. I'm not going to take time to go over the whole thing with you, but be sure to review this. Let's say you've got a colorimetric detector and it does not change colors after several ventilations. Then we got the tube in the wrong place. So we will remove it and re-intubate. Sterilization by autoclave. It's interesting because RTs don't really use autoclaves, but I've had several questions asked about autoclaves, and that is steam under pressure at 121 degrees centigrade, which is 250 Fahrenheit. You will never successfully wean the patient if the ET tube is too small. You've got to get the proper size tube. Dry powder inhaler. Instruct the patient to breathe out fully and inhale forcefully. Breathe out fully and inhale forcefully. Mixed venous blood, we already mentioned. Chest tube placement. Okay, this is important. If the chest tube is for air, then we go in at the second intercostal space at the midclavicular line. If it's a pleural effusion, that means fluid, then we go the 5th to 7th intercostal space at the anterior axillary line. All right. Smoke inhalation in the emergency room, what do we do? That should be a non-rebreather mask at 100% because we have to assume that the patient has gotten some carboxyhemoglobin. They've got some carbon monoxide inhalation, so we use a non-rebreather at 100%. Chest x-ray and emphysema, hyperlucency, increased AP diameter. Overexposure of the chest x-ray. You can clearly see the vertebrae. I think I mentioned that earlier, but just to make sure you understand, in overexposed x-rays, you can clearly see the vertebrae. Minimal leak technique. Some old-timers like me use this all the time to set the pressure in the endotracheal tube cuff. We inflate the cuff and then aspirate air until a small leak, very small leak, can be heard upon inspiration. Trach patient with subcutaneous emphysema. Well, that means that we need to check the tube position and reposition it because we've got air that's leaking out into the soft tissues. Sudden changes in transcutaneous O2 or CO2 for that matter. There might be a leak around the electrode or a loose electrode. Bronchopleural fistula. High frequency is a great way to ventilate that condition because you will not be able to get the normal seal that you would hope to get if there's a bronchopleural fistula. And then the PFT capacities, just make sure that you know how they add up. ERV plus RV is FRC. Tidal volume plus IRV is inspiratory capacity. IRV plus tidal volume plus ERV is vital capacity. All right. ARDS, if the patient is on volume control, but the PIP is very high, above 50 is generally what we consider too high, then that's when you would go to pressure control ventilation. Flow volume loops, if you see a scoop, that means a small airway obstruction. That would be a good time to give a bronchodilator. Inspiratory and expiratory films is interesting. For foreign bodies, doing an inspiratory and expiratory film can be helpful to show the air trapping that's caused by the foreign body. Blinded constrophrenic angle, well, that could be pneumonia or could be effusion. That's where you use the lateral decubitus position to see the fluid run and confirm if it's a pleural effusion. Plateau pressure, how high is too high? Plateau pressure is greater than 30, means the patient is getting stiff lungs for some reason, need to figure out why. Okay, nasal trumpet or nasopharyngeal airway, just want to make sure you know the terminology there. Treating air trapping or auto PEEP, we've covered that before. Shorten inspiratory time, so there's more expiratory time. Lengthen the expiratory time or increase the flow rate. Oh, and here's a good little example of airway resistance. When airway resistance is increasing, the difference between PIP and PLAT is increasing. The difference. So at 2 p.m., you see a difference of 15 between PIP and PLAT. But at 3 p.m., you see a difference of 19 between PIP and PLAT. So that means that airway resistance did increase in that time period. We're on number 122. This only goes to item 151, I think, so you're almost there. You've just got to review this APGAR scoring grid. 7 to 10 is the total score that we're hoping to see, but you've got to look at all of these: activity, pulse, grimace, appearance, respiration. Study the APGAR scoring system. There will be questions on this. Adjusting CO2 with different ventilators. This is very helpful. For volume control ventilators, like we use most of the time, we adjust tidal volume to control CO2. For pressure control ventilators, we adjust peak inspiratory pressure. For jet ventilators, we adjust the drive pressure. And for the oscillator, we adjust amplitude. Sniffing position. If you cannot get a suction catheter to pass for nasotracheal suctioning, reposition the patient's head to sniffing position, and you very likely will get it to go. PEP therapy, the goal is to mobilize secretions, useful for any condition like cystic fibrosis maybe, or pneumonia, COPD sometimes, where the goal is to move secretions. Thick, tenacious secretions, HMEs, they're very handy, but they're a bad idea. We want a heated humidification system if we have thick, tenacious secretions. Here's ET tube position. Let's say you've got an ET tube that's 1 centimeter above the carina. That's too close. You need to pull it back. Okay. We don't want it right on the carina or within a centimeter of the carina. Airplane and helicopter transport. One of the risks that we have in flight is pneumothorax. The patient may not have a pneumothorax on the ground, but when we take them up at altitude, the pressures change and they do get a pneumothorax. So then we would have to do needle decompression. Stridor in the ER, racemic epinephrine. Suctioning frequency, the theory has changed. We used to say, suction every time you do a vent check, or suction every time that every so many hours, but not now. We just say suction only when the patient's coughing or when you can hear or feel secretions that need to be removed. Okay, fenestrated trachs, we talked about that already. Endobronchial intubation, talked about that already. Premature infants, in addition to oxygen and CPAP, they need surfactant, and that is either Infisurf or Curasurf, but they definitely need surfactant. Okay, BiPAP and PPV. To blow off CO2, we increase the gap, the difference between IPAP and EPAP. So for example, if we're at 12/5 and we want to blow off more CO2, we go to 14/5. However, if our goal is to increase the patient's oxygen level, then we go from 12/5 to 14/7 because we keep the gap the same, but we raise the EPAP. So just like PEEP, that will improve the patient's oxygenation. Fixing CO2 and O2, important point: when the patient has both problems, we fix the ventilation first. Fix the ventilation first. That will improve the CO2 and will very likely improve the O2 also. I'm on number 136. Do you recognize the medicines for tuberculosis? Here they are: isoniazid, which sometimes is called INH, rifampin, ethambutol, and pyrazimide. Those are your medications for tuberculosis. Normal neonatal ABGs, I've listed them here. Important, a PaO2 of 60 is okay for a neonate. You don't need to give that kid oxygen. That's where nature has the neonate's oxygen. It will improve, increase over time. And there are the pulse ox levels, which are also lower than adults. Oh, vital signs. This is interesting. Double or half. A great instructor from Kettering taught me that we can say neonatal ventilators, vital signs, double or half. The respiratory rate is about double. The heart rate is about double the adult level. The blood pressure is about half the adult level. Let me leave it there for a minute while you look at that. Neonatal vital signs are about double for respiratory rate and heart rate, and about half for blood pressure as compared with adult. Here are all the different sputum colors and their meanings. Clear, white, or gray, that might be normal, or it might be a viral infection. Yellow, that's bacterial infection or chronic inflammation. Green is long-standing chronic infection, especially Pseudomonas infection. Brown or black sputum, that's old blood in the sputum. Lung cancer. Red, pink, or rust-colored sputum is the presence of blood in the sputum. That would be like active bleeding. And if the patient vomits black coffee ground looking material, then that is a GI bleed, okay? There's gastrointestinal bleeding that's been going on for a while. Acute bleeding in the GI system is bright red. You're almost done, folks. I know this has been a long presentation. Epiglottitis versus croup. Here are the classic distinguishing factors. Epiglottitis kids much sicker. Abrupt onset versus slow onset for viral croup. High fever versus moderate fever or maybe no fever in viral croup. Stridor, moderate to severe. Cough, minimal or absent. The kid with epiglottitis does not do that barking that we hear in viral croup. Drooling is very classic. Drooling is very classic in the inability to speak for epiglottitis. All right, almost done. Normal lab values, I just want to tell you, you've got to review this sheet, particularly know the electrolytes, sodium, potassium, chloride, BUN and glucose you also need to know. Know the CBC, especially the white count, red count, and hemoglobin. ABGs, obviously, you already know. Respiratory failure, you must have ABGs to make the determination as to whether it's hypoxemic or hypercapnic respiratory failure. Here's the calculation of static and dynamic compliance. Pretty sure you know that by the time you graduate RT school, but static is tidal volume divided by plateau minus PEEP. Dynamic is exhale tidal volume divided by peak pressure minus PEEP. All right. Oh, on the oscillator, count 9 ribs on chest x-ray. I've had several students inquire about that, so maybe it's on your test. Chest tubes, the drainage system, continuous bubbling in the suction control chamber is normal. That just tells you the system is working. But continuous bubbling in the middle chamber, that's the water seal chamber, probably means there's a leak. That chamber is just to create the seal, and if there's a leak, you will see bubbling there. Hemodynamics, folks, you're just going to have to know the hemodynamic levels, and they're all right here for you to review. Swan-Ganz catheter. This shows you the path of the Swan-Ganz catheter as it moves through the heart. You could have something about this or something about the various pressures in the various chambers. You can see the catheter moving through the right atrium into the right ventricle where the pressures increase, then the pulmonary artery, and then when the balloon is inflated in the wedge position. And there are the pressures. Aspiration. So let's say the patient aspirates. Let's say a nursing home patient. They aspirate. First thing to do is suction, get as much out as you possibly can, and then put the patient on the opposite side to facilitate drainage. And auto PEEP. I think this might be the last item. When auto PEEP is present, the flow volume loop shows that expiratory flow has not returned to baseline before the start of the next breath. So you can see in this graphic that flow does not get back to the baseline before the next breath starts. And that is auto PEEP shown graphically. Very important concept. And folks, you survived it. That's the review sheet for 2017. Hopefully helpful. I know there were a few duplicates in there. The reason there would be a few duplicates is because multiple students asked about those particular things. So I'm not sure that it's really a bad thing that we had a few duplicates. It's probably a good thing. Folks, I wish you all success on your TMC exam. I have enjoyed putting this review together for you, and I hope you found it helpful. Feel free to write to me with any questions. Deryl.Gulliford, that's DERYL.GULLIFORD independence.edu. And also, you could simply text me at 405-219-6715. 405-219-6715. I wish you success on your exam and your career in respiratory therapy.